All right, good morning, everyone. I'm Omar, one of the PGY3 Merge residents, and I will be spending the next hour discussing cardiogenic shock. Now, the motivation for this talk came from two cases that I had encountered early in residency, which I will go through shortly, but it made me think how challenging this diagnosis can be. And I'm sure many of you have encountered patients that were in cardiogenic shock. And I'd like you to think about what stood out and what, if anything, made it difficult. Feel free to use the chat for any commentary or questions you may have along the way. And Dr. Dorandrew will be assisting me with moderating the chat at the end. Before I continue, I have to acknowledge the people who provided their invaluable feedback and who have truly enriched the quality of this talk. I want to thank the cardiology staff, including Dr. Cheat, who's the heart failure lead for the shock program, Dr. Froschel, an interventional cardiologist, as well as the cardiology fellows who provided insight into the consultations they see from our colleagues and things they'd like to impart on us. I'd like to especially acknowledge Dr. Matthew, a cardiac intensivist and a local expert, who took the time to provide our expertise surrounding this topic, and to Drs. Ritzy and Thabnathan for providing their POCUS expertise, to Drs. Cortel LeBlanc, Wilson, and Bradley, who have helped enhance this presentation. And I can't thank my supervisor enough, Dr. Hendon, who has been an awesome support throughout the making of this talk. And finally, to my fiance, Dr. Butto, who might be here virtually, who has listened to this and heard me talk about cardiogenic shock way too many times. Okay, so let's first talk about why this topic matters. Imagine that your next patient, John, arrives at your emergency department. He experienced chest discomfort 3 days ago, but unfortunately did not seek care at the time, stayed at home only to get progressive shortness of breath and fatigue over the next few days. His wife calls 911, and you see him now with this set of vitals. He has decreased mentation, he's cold and mottled throughout, and has increased work of breathing. John has suffered a massive MI, but it's a good thing he's here because he still has viable myocardium. You activate code STEMI. John's LED is likely occluded, limiting vital blood supply to the LV, the pumping powerhouse of the heart. You recognize that John is in cardiogenic shock and start initiating therapy to keep his vital organs perfused. This is Mary. She has multiple comorbidities, including heart failure with reduced ejection fraction and severe COPD. She presents with a 1-week history of worsening shortness of breath and cough. She's found to be in new rapid AFib and in respiratory distress. You're unsure whether this is heart failure, COPD, pneumosepsis, or multifactorial. So you treat empirically. You start heart failure management, start on antibiotics as well as some puffers and steroids for COPD management. Mary gets admitted to medicine. But 3 days later, she's diagnosed with cardiogenic shock and transferred to the CCU. Mary's presentation is not uncommon, and we see patients like her all the time. It's not readily obvious that she's in shock. Her LV has been failing for many years with the most recent EF of 26% a few months ago. Her severe COPD has resulted in pulmonary hypertension, and that, along with her LV dysfunction, has caused her right side to fail. She gets an infection, her pump goes under stress, and she's unable to maintain an adequate cardiac output. Her heart compensates by racing faster. We will see Mary many times in the ED, and while sometimes we will correctly diagnose her, there will be other times when we will miss this diagnosis. And that's okay because cardiogenic shock is difficult to diagnose. It has diverse presentations, sometimes overlaps with other shock states, and we still have a poor understanding of pathophysiology and often get varied hemodynamics in patients. For these reasons, it's often under-recognized and challenging to diagnose. It carries a high mortality rate. In-hospital mortality varies between 40 to 60%, with nearly 1/2 of deaths occurring within the first 24 hours. Another 20% of deaths occur in the first 2 months after onset, suggesting that the risk of death is highest in hospital and in the early post-discharge period. So for us, early recognition and intervention improves survival. The Johns of cardiogenic shock are obvious. The Marys, not so much. And my goal today is to provide you the tools to improve your hit rate on identifying cardiogenic shock and provide you the evidence and expert opinion on how to manage this condition in the emergency department. When the pump fails acutely, it's relatively easier to identify the condition. But when there's a slow progression of disease, such as in decompensated heart failure, dysrhythmias, cardiomyopathies, cardiogenic shock may be a bit more elusive than we think. And to complicate matters further, while the majority of cardiogenic shock occurs due to underlying ACS, its contribution has declined over the past 2 decades, with a parallel increase of other etiologies such as heart failure. Recent epidemiological data from a Canadian and US CCU data registry showed that only 20% of patients had cardiogenic shock due to ACS, with another 50% due to non-ACS etiologies. And the reason for this is partly because of advancements in STEMI bypass and revascularization therapies. Less people are coming in sick with heart attack associated shock. On the other hand, as people are living longer, we're seeing more advanced stage heart failure, which is contributing to the increasing prevalence of heart failure associated shock. An additional 20% of patients from the same registry had mixed shock. These patients had higher SOFA scores, higher ICU resource utilization rates, and worse in-hospital mortality. And so, while cardiogenic shock due to ACS remains an important consideration, non-ACS etiologies and mixed shock is important for us to recognize as they're associated with higher morbidity and mortality. So why does it matter? Well, it matters because early recognition and intervention improve survival. It also matters because we're going to see more and more of this as patients with end-stage heart failure live longer. This talk is going to be divided into 3 sections. We're going to discuss how to recognize this clinical entity, followed by selected therapies to initiate in the ED, and finally, how to temporize the tachycardic patient. If there are any slides to pay closer attention to, these summary slides will have actionable take-home points. And along the way, we'll have various bites of insight and opinion from our local experts. Let's first talk about recognition. We're going to take it back to 1999 when the SHOCK trial was published. This was one of the first landmark trials to pave the way we define and think about cardiogenic shock. This trial showed us that when patients with MI and cardiogenic shock undergo emergent PCI, they have a significant survival benefit at 6 months. The authors defined cardiogenic shock based on hemodynamic criteria such as cardiac index less than 2.2 and capillary wedge pressure greater than 15. Many subsequent landmark trials reported similar but their own unique definitions for cardiogenic shock to standardize patient recruitment. The investigators of newer trials such as IVP shock 2 or culprit shock realized that invasive hemodynamic criteria is not really needed to diagnose this clinical entity. In fact, most trials and guidelines now define cardiogenic shock based on clinical criteria alone. And so, if we were to summarize the commonalities amongst all of these trials and guidelines, it all boils down to 4 features. It includes evidence of hemodynamic instability, evidence of cardiac dysfunction, signs and symptoms of hypoperfusion, and lab markers of end organ dysfunction. Unfortunately, one size does not fit all. The reality is that many patients fall on a spectrum and can have the classic wet and cold phenotype that we all learn about, but can also have relatively benign hemodynamics and have occult cardiogenic shock. So in 2017, a group of cardiologists decided to address this lack of universal definition for cardiogenic shock. A working group was formed by the Society for Cardiovascular Angiography and Interventions group. This working group included cardiologists, intensivists, as well as emergency physicians. The SKY group worked to conceptualize and define cardiogenic shock along a continuum rather than a static state. And so they developed this classification system. It was designed to be simple and allow easy applicability at the bedside, with the goal of facilitating communication between providers and streamlining clinical decision-making. SKY A are those individuals who are at risk but don't have signs and symptoms of cardiogenic shock. SKY B are those who have occult shock, relative hypotension, and tachycardia, but no overt signs of hypoperfusion. And SKY C is the classic cardiogenic shock state that we see and includes those who have signs of hypoperfusion and those that require interventions such as pressors and inotropes. And SKY D and E are those who have failed initial interventions or are in extremis. This classification system has been endorsed by many critical care and cardiology societies. It's been validated across many clinical settings and has prognostic discriminatory potential. In a retrospective cohort study by the Mayo Clinic of over 10,000 patients, there was a strong association between SKY shock stages and mortality, emphasizing the robustness of this classification system. And similar discrimination has been seen in multiple subsequent cohort studies that have been conducted in North America. We can simplify it a bit more by thinking of patients in SCI-B to be in the pre-cardiogenic shock state, and SCI-C as the classic cardiogenic shock state. And so, who are these patients? Well, common ED presentations may include for SCI-A, mild CHF or chronic CHF patients. For SCI-B, these are the patients who are in decompensated heart failure and those that may have tachycardia-induced cardiomyopathy. In SCI-C are patients who may include post-ROSC from a primary cardiac event and the classic wet and cold patients. Now, even if you choose not to adapt this classification system in our practice, the important thing to recognize is that this clinical entity occurs on a spectrum and that patients with decompensated heart failure could lie on that spectrum. The reality is that SCI-A to C are the stages that we will see in the emergency department. So to own cardiogenic shock, this is where we can make a lot of difference. Let's summarize what we've talked about. Cardiogenic shock is a clinical diagnosis and exists on a spectrum. Our experts feel that SCI classification allows us to speak the same language and can be helpful in prognostication and guide treatment decisions such as mechanical circulatory support. Okay, so let's move on to vital signs. When the heart fails, your stroke volume decreases. As a compensatory mechanism, your heart rate goes up to maintain cardiac output. In decompensated heart failure, systemic vascular resistance, or SVR, and subsequently afterload increases. This is what we usually see in the SCI-B patients or the pre-cardiogenic shock state. And this compensatory mechanism is also why we cannot entirely rely on blood pressure to evaluate for perfusion or cardiogenic shock. In fact, a subset of patients with cardiogenic shock do not have hypotension, but rather signs of hypoperfusion. In the shock trial, approximately 6% of patients had a normal blood pressure, however had signs of hypoperfusion and tachycardia. Eventually, what happens is that this compensatory mechanism becomes maladaptive and causes worsening hemodynamics. As coronary perfusion decreases with worsening myocardial function, we see a systemic inflammatory response that ultimately results in the cardiogenic shock spiral of death. This maladaptive process ultimately causes vasodilation and decreases your SVR. So, to put it all together, what we often see in the spectrum is compensatory rise in heart rate and SVR, followed by changes in your microcirculation due to a progressive inflammatory response and subsequently a paradoxical decrease in your SVR due to vasodilation. This becomes important when we think about how to treat these patients, which we will touch on later. Another clue in the vitals that can help you is narrow pulse pressure. This is the systolic pressure minus the diastolic pressure. If these two values are close, either less than 20 or 25% of the systolic value, this may be seen states of poor forward flow. Your heart simply is not generating the pressure against the resting diastolic pressure. Let's summarize what we've talked about. Tachycardia is often compensatory to maintain cardiac output, and this is one of the reasons why we cannot entirely rely on blood pressure. And our experts agree with this. The normotensive patient may still be in cardiogenic shock, and so it's important to look at clinical clues that may raise your suspicion of this diagnosis. So what exactly are these clinical clues? Let's dive into some of the tools you can employ at the bedside. The most important one being point-of-care ultrasound. POCUS is indispensable in your assessment for cardiogenic shock, and I would argue that you simply cannot diagnose this condition otherwise. You have to ask yourself two questions. The more important one, is there cardiac dysfunction? And as a reminder, contractility can be estimated by fractional shortening or EPSS. Fractional shortening less than 30% indicates reduced LV function, and EPSS greater than 7 is 100% sensitive for predicting LV dysfunction. In the peristernal long view, the closest distance between the septum and the anterior mitral valve leaflet during diastole defines the EPSS. The second question to ask yourself is whether there's evidence of pulmonary edema. As a reminder, this can be determined if diffuse B lines are seen in greater than 2 zones on both sides of the chest. B lines are hyperechoic vertical artifacts that originate at the pleural line and extend to the bottom of the screen without fading. Now, to take it another level, as emergency physicians, I feel that we're uniquely positioned to diagnose and evaluate for valvular pathology, as this can truly change disposition. In the context of acute decompensated heart failure or cardiogenic shock, a diagnosis of severe MR may change management by informing a mechanical solution. So, to evaluate for severe MR, place the Doppler window over the left atrium and through the mitral valve. The color flow jet should reach the back wall or cover greater than 50% of the left atrium. This is a comparison of mild MR versus severe MR. Again, you can appreciate that if the color flow jet reaches the back wall or covers greater than 50% of the left atrium, you should suspect severe MR. Another feature to look for is RV dysfunction, as this may be important in guiding initial therapy. The D sign, RV size greater than LV on apical four-chamber, and TAPSE are other POCUS features of RV dysfunction. TAPSE is the distance traveled by the lateral tricuspid annulus towards the apex of the RV during systole. And various cutoffs are used, but TAPSE less than 17 is consistent with severe RV dysfunction. So let's move on to physical exam. The most important feature is going to be looking for signs of hypoperfusion. Cool skin is more common in cardiogenic shock than other types of shock. 2 retrospective reviews demonstrated that those with cardiogenic shock compared to those with distributive or hypovolemic shock were more likely to have cold skin. Other signs of tissue hyperperfusion include skin mottling and capillary refill time. These are under-recognized features of hypoperfusion. Last year, Dr. Garrick Mock presented his grand rounds on microcirculatory endpoints of septic shock and discusses these 2 very important features in more detail. The more we learn about shock, the more we learn about the importance of microcirculation. So it's extremely helpful to identify these often subtle findings on exam. Altered mental status, thready pulses, and oliguria are additional features of hypoperfusion in cardiogenic shock. And while no single finding is specific, these are small pieces of the puzzle to help you in identifying the patient who may have signs of hypoperfusion. In fact, the SCAI system has various descriptors for physical exam findings to aid you in classifying the patients. SCAI-C patients, or those in the classic cardiogenic shock state, may have any of these signs. Now, we're all well versed in this, but it's important to identify signs of congestion. Approximately 80% of patients with cardiogenic shock present in respiratory distress. This is usually because LV dysfunction causes elevated filling pressures and subsequent pulmonary edema. A meta-analysis by Martinelli et al. Provides insight on specific physical exam findings seen in patients with decompensated heart failure, a precursor to cardiogenic shock. But it's important to note that no one finding for congestion is necessarily diagnostic, but rather they're data points to add to your suspicion for a patient who may have pulmonary or systemic congestion. What may be a bit more helpful are lab markers of hypoperfusion and end organ dysfunction. Let's discuss 2 of them. The prognostic value of lactate in cardiogenic shock has been proven in several studies. In contrast to patients in septic shock, where the severity of lactate elevation does not necessarily correlate to the severity of illness or prognosis, higher lactate levels means poorer prognosis in cardiogenic shock. In 4 observational studies, elevated lactate greater than 2 was associated with an increased mortality, with an odds ratio ranging from 1.4 to 6.7. Lactate is an important prognostic marker. In fact, the SCAI classification incorporates lactate as one of the identifying features. SCAI-C patients, or the classic cardiogenic shock state, can potentially have lactate greater than 2, whereas those in SCAI-E may have a lactate greater than 5. Elevated ALT and AST is also common in cardiogenic shock and is due to a combination of hypoperfusion and venous congestion. This may reveal early signs of hepatic injury. Note that this is not the same as shock liver, where you may have extreme elevations of LFTs. Two large studies provide some evidence that elevated ALT and AST may be associated with increased mortality. In the 2017 Card Shock Registry study, approximately 60% of patients in cardiogenic shock had elevated ALT. When these same patients had a greater than 20% increase in ALT over 24 hours, they were found to have higher mortality. And in a sub-analysis of the IVP Shock 2 trial, patients with elevated ALT and AST had a 68% 30-day mortality rate. Now, while there are limitations to these studies as they were performed in patients receiving CCU care, these LFT markers were independent predictors of mortality. And even if these studies were not done in the emergency department, there's a signal that early signs of hepatic injury may be prognostic for patients in cardiogenic shock. Again, if we were to look at features of the SCAI classification, patients with elevated ALT and AST may fall in the SCAI-C category. And finally, it goes without saying that ECG and a cardiac workup is also important because ACS remains an important etiology for cardiogenic shock. All of the clinical tools we discussed should provide you data points to aid in your diagnosis of cardiogenic shock. At the end of the day, they incorporate all of these features. Again, you need to have some evidence of hemodynamic instability, cardiac dysfunction, clinical and lab markers of hypoperfusion and end organ dysfunction. To summarize, we need to employ a combination of vital signs, POCUS, physical exam looking for hypoperfusion and congestion, as well as lab markers to raise our suspicion of cardiogenic shock. Our cardiology fellows believe that we should be getting a lactate and LFTs in every decompensated heart failure to evaluate for occult cardiogenic shock. Okay, so this is all great, and you may be saying, Omar, we get it. I need to POCUS these patients. I need to look for hypoperfusion and get biochemical markers. No problem. This all makes sense. But how do I go about treating these patients? What's the ideal agent? And how do I make sure that this patient in cardiogenic shock in my resus bay remains alive before heading to the CCU or cath lab? Well, the key to that answer is thinking about two things. The first is coronary perfusion pressure. The heart in cardiogenic shock is already dysfunctional, and so to optimize blood flow to the viable myocardium, we need to think about coronary perfusion pressure. The LV is perfused almost entirely during diastole because the coronary arteries during systole are not compressed as they are in systole. And during this state, the only counting pressure is the LV end diastolic pressure, which is the filling pressure at the end of diastole, or when the LV is relaxed. So to optimize coronary perfusion pressure, you need to think about agents that will increase your MAP or SVR, and you need to think about agents that will decrease congestion or filling pressures. The second thing to think about is again this idea that in patients with worsening cardiogenic shock state, the SVR tends to drop due to that inflammatory response. So again, you need an agent that improves the squeeze of your arteries and increases SVR. And that agent is norepinephrine. Norepi is universally endorsed by the Canadian Cardiovascular Society, American College of Cardiology, and European Society of Cardiology as the first-line agent for patients in cardiogenic shock. This is based on the available evidence that norepi has performed better in head-to-head trials than other vasoactive agents such as dopamine, vasopressin, and epinephrine. One of the earlier trials to demonstrate this was the SOAP2 trial, when at the time, dopamine was still widely used. This trial included over 1,600 patients in various types of shock. In the subgroup analysis of patients in cardiogenic shock, dopamine compared with norepinephrine was associated with an increased rate of death at 28 days. Norepinephrine makes sense. It increases your SVR, has minimal effect on heart rate, and has some beta-1 activity to help with inotropy that is needed in these patients. It also has the added benefit of counteracting the vasodilatory effects of inotropes, which we will touch on later. And as we discussed earlier, when you don't know what etiology of shock a patient may have, or if there's an element of mixed cardiogenic septic shock, norepinephrine also makes the most sense, as it's the first line for other types of shock as well. So to summarize, norepi should be the first line agent for initial circulatory support and to optimize coronary perfusion. Our experts agree that this should remain our first line agents. Another agent that is sometimes used as an adjunct is vasopressin. Vasopressin is an interesting drug in that it causes systemic vasoconstriction and increases SVR, but in the lungs, it has vasodilatory properties at low doses and causes pulmonary vasodilation through a nitrogen oxide dependent mechanism. The patients to consider vasopressin are those who have underlying pulmonary hypertension, evidence of RV dysfunction, or evidence of biventricular dysfunction, as unloading the RV improves LV filling due to ventricular interdependence. And so we can use vasopressin as an adjunct if we're suspicious clinically of right-sided dysfunction. Our cardiac intensivists often use vasopressin as a second-line vasoactive agent. They feel that even if there's no evidence of RV dysfunction, unloading the RV helps improve filling of the LV. Okay, let's talk about epinephrine. Recent evidence has shown that its use should be avoided in patients with cardiogenic shock. One of the biggest trials to demonstrate this was the Optima CC trial. This was a large multi-centered RCT conducted in 9 French ICUs that randomized patients with acute myocardial infarction associated cardiogenic shock to either norepinephrine or epinephrine. And refractory shock was seen in 37 patients of patients receiving epinephrine, compared to only 7% of those receiving norepinephrine, with a number needed to harm of 3. And the trial was actually subsequently stopped early. In one of the strongest evidence to date, a recent individual patient data meta-analysis of 15 studies and over 2,500 patients with cardiogenic shock, epinephrine use was associated with increased risk of short-term mortality compared to norepinephrine, with an odds ratio of 4.4. So why is that? Well, epinephrine is like putting yourself on a running treadmill immediately after you've ran a marathon. It's going to worsen the demand on your heart against an already limited supply. Dr. Renee Bradley last week discussed the effects of epinephrine in out-of-hospital cardiac arrest. And while more evidence is needed to clarify if we're harming patients with too much epinephrine, what's becoming clear is that when you achieve ROSC and there's evidence of cardiogenic shock, epinephrine should be avoided in these patients. What's going to save them is opening up the culprit lesions through PCI. To summarize, we should be avoiding epinephrine as it's associated with increased mortality. Now, most of the evidence we have for epi is with patients who have had an acute myocardial infarction. The challenge in the ED is that we may not be able to identify whether ACS is contributing to cardiogenic shock. Our experts feel that if there's any whiff of ischemia in the patient's clinical presentation, we should not be using epinephrine. Better yet, and to be safe, we should completely avoid it as there are better agents out there, such as norepinephrine and vasopressin. So this wouldn't be a cardiogenic shock grand rounds if I didn't talk about the decade-long debate on dobutamine and milrinone. The first thing to note is that recent American and European cardiology societies recommend that inotropic support should only be used if necessary. They give these agents a class 2 indication. And the reason for this is that some studies have actually shown that its use may be associated with increased mortality in patients. So my recommendation is that we only use an inotrope if there are ongoing signs of hypoperfusion and only after starting norepinephrine. Both DOB and milrinone have benefits in augmenting cardiac output and have similar effectiveness and safety profiles. Let's talk about dobutamine first. It has the benefit of being fast on and fast off. There's dosing familiarity to it, and we know how to use it. The drawbacks are that it can be arrhythmogenic, and this is particularly harmful in patients who are post-ROSC from a primary cardiac event. Dobutamine can worsen the heart rate, which tends to already be elevated, and it can cause a phenomenon known as tachyphylaxis in patients who are on chronic beta blocker therapy, as higher doses are required to achieve the same effect. Milrinone, on the other hand, works independent of the beta receptor, as it's a PDE inhibitor, and can help augment cardiac output, especially in patients treated with chronic beta blockers. It also has the added benefit of unloading the RV due to its effects on decreasing peripheral vascular resistance. Now, the problem with milrinone in the emergency department is that it's less titratable. And because it acts on the vascular bed through cyclic AMP, it causes more peripheral vasodilation than dobutamine. It's also cleared by the kidney, so patients who have concomitant AKI or renal failure may accumulate this drug. The debate goes back many years, but luckily, Dr. Matthew published a systematic review and meta-analysis of 11 studies, which helps synthesize the available evidence. 6 studies reported in-hospital mortality, which was included in the primary meta-analysis. Now, there was no observed difference between DABA and milrinone, although a trend towards reduction in mortality was observed with milrinone. 3 studies showed that there was lower long-term mortality at 1 year with milrinone compared to dobutamine. And length of stay was also studied. And while there was no difference in the overall length of stay, patients in the ICU had a shorter length of stay with dobutamine compared to milrinone by only 1 day. And significant arrhythmias were no different between the 2 groups. So while there are some signals in there, based on the available evidence, and comparative studies have failed to show significant differences between the 2 agents. Now, this is a timely topic because locally, the Capital Do-Re-Mi trial was an RCT that was conducted at the Heart Institute. While I can't share the formal results of this study, overall, they did not find a significant difference in the primary outcome. This is an exciting landmark trial that was recently accepted and should be published in the New England Journal of Medicine within the next few months, so definitely keep an eye out. So where do we land? Well, I think based on the available evidence, we need to acknowledge the clinical equipoise that currently exists. There's some signals on the benefits of mortality on milrinone, but a lot of that data is confounded by sampling bias and observational studies. Practically, however, I feel dobutamine makes more sense in the ED setting. It's rapidly titratable, so if you don't see an effect or observe dysrhythmias or hypotension, you can turn it off. The important thing is to start norepinephrine for initial support prior to inotrope selection. And our experts agree with this. Currently, there's no strong data for the use of one over the other. So we've talked about addressing hemodynamics with MAP and SVR, but what about congestion? Remember, coronary perfusion pressure decreases with elevated filling pressures within the chamber of the heart. Let's talk about how we can address this. The benefit of IV diuretics is often underrecognized, and this therapy is sometimes deprioritized in cardiogenic shock. When we do use it, we need to appropriately dose it. Furosemide has a ceiling effect, and the IV formulation tends to have a much higher peak concentration than the PO dose. And a mechanism that we often forget is that it can act as a venodilator due to its effects on the RAS system and vascular prostaglandin synthesis. And so acutely, it can help relieve congestion and decrease filling pressures. So the bottom line is we should use it, and we should use a big dose of it. Common doses that cardiology recommends are 120 milligrams IV for the diuretic resistant and 60 milligrams IV for the diuretic naive patient. And because pulmonary congestion is so common in cardiogenic shock, patients often present with respiratory distress. A 2019 Cochrane review included 24 studies that compared standard medical therapy versus non-invasive positive pressure ventilation. And compared with standard medical therapy alone, non-invasive positive pressure ventilation reduced hospital mortality with an NNT of 17, and also reduced intubation rates with an NNT of 13. So to summarize, we can unload the heart by using a large dose of IV diuretics and non-invasive ventilation if there's signs of respiratory distress. In the last 15 minutes of my talk, I will be going through what we can do to temporize patients in acute decompensated heart failure who either have tachycardia or atrial tachyarrhythmias. As a reminder, we know that the heart rate goes up to compensate for the decreased stroke volume in the setting of a failing heart. There are 3 principles to keep in mind when dealing with tachycardia. First is that we need to be comfortable with it and recognize that this compensation is necessary to maintain forward flow. The second is that if patient is stable and whenever possible, treating the underlying cause will help treat the tachycardia more than anything. And the third is that POCUS can be helpful in identifying some of these underlying causes, such as LV dysfunction. So let's talk about what not to do first. Rate control with beta blockers and calcium channel blockers should be avoided because the risk of cardiac decompensation is high due to their negative inotropic effects. While these are important therapies, initiation of these agents should be done in closely monitored inpatient settings once patients have diuresed and trended towards euvolemia. So in the ED, we should not be using these agents for rate control. The CCS guidelines on AFib and the CAPE AFib best practices checklist recommend to avoid rate control if the cause of the tachyarrhythmia is secondary to a medical cause, or if it's due to heart failure, LV dysfunction, hypotension, or if the patient has signs of shock. Similarly, electrical cardioversion carries additional risks, as both transient myocardial stunning and procedural sedation can cause a low cardiac output state. In a failing heart, this can push patients from a pre-cardiogenic shock state into the cardiogenic shock state. So in the ED, electrical cardioversion has a limited role for these patients. But when can you electrically cardiovert somebody? Well, patients who are clearly unstable, who have persistent hypotension, have ventricular tachycardia, or who have a heart rate greater than 150, where the heart may not have adequate filling time, may be the ones to benefit from cardioversion. If you choose to do so, I recommend starting a norepinephrine drip or having phenylephrine pushes, as the risk of cardiac decompensation may be high. Similar to electrical cardioversion, the use of amiodarone or procainamide should also be avoided in these patients, as converting the patient back to a slower sinus rhythm may further decompensate their hemodynamics and increase the risk of stroke, especially if the onset of their tachyarrhythmia is unclear. And so in the ED, we should be avoiding these agents. To summarize, patients treated with negative chronotropic agents or cardioversion may be pushed in a slow sinus rhythm without the ability to mount a compensatory tachycardia. For patients with systolic dysfunction, this can precipitate cardiogenic shock. Now, our experts treat patients with beta blocker or calcium channel blocker induced cardiogenic shock on a monthly basis. We should really be looking out for patients who are running fast and who may be in decompensated heart failure. When it's not entirely clear, using POCUS, physical exam, and biochemical markers that we discussed can help us identify those that may have occult cardiogenic shock. And if a patient has rapid AFib with unclear onset, and there are any signs of decompensated heart failure, the cardiology fellows do not mind being called about these patients. So what can you do about these patients? Say you have a 58-year-old female who presents to your ED with a 3-week history of progressive shortness of breath, bilateral leg swelling presenting with this set of vitals. She's in rapid AFib. You identified that she may be in decompensated heart failure from a tachycardia-induced cardiomyopathy. In fact, she would fall into the SCI-B category or pre-cardiogenic shock state. You do a POCUS and feel that she may have reduced contractility, but it's hard to appreciate because she's going fast. So you send a cardiac workup. Clinically, her heart rate is anywhere between 130 to 140, but you're comfortable with this for now because she's not unstable and this may be secondary to her heart failure, and she may be compensating for the reduced stroke volume. You start with aggressive diuresis with 60 milligrams of IV Lasix and place her on some oxygen. You know that you should not rate control or cardiovert her, especially because of her symptoms and unclear onset. So you wonder if there's any other medication that you can give her. And that medication is digoxin. Digoxin has been used for centuries to treat patients with heart disease. Its role in the management of AFib and heart failure has been challenged over the past decade, and its prominence in consensus guidelines has minimized. This is in part due to the publication of the DIG trial, which showed no mortality benefit from DIG in heart failure patients with sinus rhythm. However, I would argue that DIG does have a role and remains an important treatment option for patients with rapid AFib and decompensated heart failure. A poor understanding of digoxin's limitations can lead to inappropriate use of this agent and may explain the recent associations between DIG and increased mortality. When I went digging into the literature, I found way too many meta-analyses that have been performed that evaluated the use of DIG in patients with AFib and mortality risk. While some studies demonstrated a higher risk of death, there were others that yielded conflicting results. So if we were to look at all the available evidence, we see that in patients with heart failure alone, digoxin has been shown to reduce hospital admissions with no effect on mortality. In those with AFib alone, the data is inconclusive due to biased observational data. And for patients with heart failure plus atrial fibrillation, there's no clear effect on mortality, and there may be a signal in reducing hospital admissions. One thing that is well established is its ability to achieve rate control. Digoxin reduces heart rate in all comers. And so, in my opinion, the association between DIG and increased mortality is inconclusive, and the higher mortality in AFib patients is in observational studies is likely due to residual confounding. Interestingly, many of the meta-analyses fail to account for the influence of serum DIG concentration on mortality. In a comprehensive post-hoc analysis of the DIG trial, serum digoxin concentration less than 1 was associated with reduced mortality, whereas concentrations greater than 1 was associated with higher mortality rates. The authors concluded that in appropriate patients, i.e. those with HFrEF and rapid AFib, low doses of DIG targeting a concentration less than 1 may be an effective heart rate control agent, especially when given as an adjunct to other heart failure therapies. What about when we compare patients who have LV dysfunction to those who don't? Two meta-analyses demonstrated that the risk of mortality was more prominent for patients who had AFib without LV dysfunction than patients that did. There seems to be a signal based on these two meta-analyses that DIG may be beneficial when used for rate control in patients with AFib with reduced LVEF. However, it should be noticed that this information comes from retrospective analyses and observational data, not randomized control trials. So, in the emergency setting, how can we use DIG to our advantage? Well, its rate control effects are well established. Knowing that the longer-term mortality benefit may be controversial, we can still use this medication in low doses, and especially in those that may have signs of LV dysfunction. IV digoxin loading can achieve rate control as early as 1 hour. And for patients with AKI or chronic kidney disease, we can still use digoxin. Knowing that it will stay in the system longer, the recommendation from our cardiology colleagues is to use a lower dose initially and communicating that we have loaded the patient with DIG so that it can be dosed appropriately. To summarize, digoxin loading may be beneficial in patients with atrial tachyarrhythmias and decompensated heart failure. Our experts want to convey the idea that digoxin loading has minimal harm to patients. Even if there are signs of renal insufficiency, we should not hesitate to load with digoxin if we feel some level of rate control should be achieved. The main toxicity occurs during the maintenance phase. So I know that was a jam-packed hour, 45 minutes, but I hope that this talk has provided you the tools, clinical evidence, and expertise to improve your hit rate on diagnosing cardiogenic shock. To consolidate what we've talked about, I hope that you can appreciate that cardiogenic shock is a clinical diagnosis and exists on a spectrum. We should use a combination of POCUS, physical exam findings looking for signs of hypoperfusion and congestion to improve our recognition. We should look out for elevated lactate or LFTs, specifically ALT and AST, to identify occult shock. We should reach for norepinephrine first, with vasopressin as an adjunct if needed, and start dobutamine only if there are ongoing signs of hypoperfusion. And we should be avoiding epinephrine. We should be comfortable with tachycardia and avoid cardioversion or rate control in these patients. And DIG loading may be beneficial in those with atrial tachyarrhythmias and decompensated heart failure. So the next time you see patients like Mary and John, I hope that you feel better equipped in recognizing and initiating therapy on this very important clinical entity, because what you do in the emergency department will make a difference in their clinical outcome. Thank you everyone for listening, and I will open it up for any questions or discussion you may have.